Good morning all. So today we will discuss about the female sex hormones and the drugs that are associated with female sex hormones. So the main two female sex hormones are estrogen and progesterone, which you have already read in the physiology. So you know something about the actions of estrogen and progesterone and how they regulate the normal female sexual hormones different activities. You know something from the physiology. So the estrogen is the main female sexual hormones, and there are three forms of the estrogen. Probably you have known. What are the three forms? These three forms are the estradiol, estrone and estriol. Okay, estradiol, estrone and estriol. These three are the three forms of the natural estrogen. Of this, the estradiol is the main or predominant form of estrogen in normal menstruating females. That is premenstrual, premenstruation, normal menstruating female before the menopause, premenopausal women. So in premenopausal women, the main estrogen hormone is the estradiol, and some part of this estradiol is converted to estrone and estriol. But the main estrogen hormone becomes estrone and estriol when there is some pregnancy. Okay. And after estrogen, the next hormone is the progesterone. And this estrogen and progesterone mainly acts in concert to maintain the menstrual cycle. So you know that there are two phases of the menstrual cycle. The first phase is the follicular phase and the next phase is the secretory phase. And in between there is ovulation. So what happens? So after menstruation, the first day starts and the uterine endometrium gradually getting builds up, and this building up of endometrial cells happens under the influence of estrogen, and this estrogen is synthesized in the ovary. This is synthesized in the Graafian follicles of the ovary, synthesized from the corpus luteum. Okay. And these are synthesized from the cholesterol. So cholesterol is the precursor molecule. You have read in the physiology and biochemistry that from the cholesterol, different steroidal hormones are synthesized. So estrogen is also a steroidal hormone, but some newer synthetic non-steroidal estrogenic components are also synthesized now. So estrogen is a steroid hormone, which is the main female reproductive hormone. There are three forms of the estrogen: estradiol, estrone and estriol. Of this, the estradiol is the predominant form in the normal menstruating women. And after the menopause, so postmenopausal women, the main hormone becomes estrone and estriol, and also in the pregnancy. Now, in the follicular phase, the estrogen starts rising, more of secretion happens from the Graafian follicles of the ovary. And this happens under the influence of the follicle stimulating hormone, FSH. So FSH and LH, these are released from the pituitary, and FSH helps in the secretion of the estrogen from the Graafian follicles of the endometrium. And before ovulation, there is a pre-ovulatory surge of the FSH that also leads to a transient increase in the estrogen level. And after that, ovulation happens. After ovulation, again the estrogen continuing secreting from the corpus luteum. That it has been changed into corpus luteum, but the secretion of the estrogen falls and the secretion of the progesterone becomes more. So the estrogen secretion falls and progesterone secretion moves, so that the endometrium, the cytology of the endometrium changes from the follicular phase to the secretory phase. So before ovulation, there is follicular phase that is mainly tackled by the estrogen, and after ovulation, there is the secretory phase that is mainly tackled by the progesterone. But estrogen, progesterone, both hormones are secreted, but progesterone takes over. And after that, at the end of the menstruation cycle, the menstruation happens. Okay, and the cycle ultimately continues. But if there is pregnancy happens, so corpus luteum ultimately persists, and this corpus luteum continues secreting more and more both estrogen and progesterone. and it becomes more, and in normal menstruating women, the estrogen secretion is approximately 10 to 100 microgram per day. Okay, 10 to 100 microgram per day, normal estrogen secretion in case of the women. It becomes very much increased in case of the pregnancy, and in second trimester of pregnancy, the estrogen secretion reaches up to 20 milligram per day. So from microgram to milligram, 20 milligram per day. Okay. And after the menopause, so when the menopause happens, there is drastic decrease of the estrogen levels, and the estrogen secretion becomes merely approximately 2 to 10 microgram per day. 2 to 10. So normally 10 to 100 microgram per day. After the menopause, it becomes 2 to 10 microgram per day. During pregnancy, it becomes very much increased. During second trimester, it becomes at the level of milligram, approximately 20 milligram per day. And in males also, there is small conversion of the testosterone and some androgen to the estrogen, and it happens approximately 2 to 20 microgram per day. So in males also there is estrogen, and the estrogen concentration is at the level of, you can say, like that of the postmenopausal women. So approximately 2 to 20 microgram per day, and this estrogen is very much beneficial for the normal bone growth and development. So without estrogen, in case of the males also, the bones will be osteoporotic. So for the osteoporosis, in case of the postmenopause, you have already read in the calcium chapter that the bisphosphonates are used in postmenopausal osteoporosis. You have read about the osteoporosis, where the calcium, vitamin D and different other agents can be given, and the testosterone and estrogen, these two hormones are instrumental in maintaining the bone architecture. So when there is decrease of the both estrogen as well as the testosterone, there will be osteoporosis. So in osteoporosis treatment, one drug you have read is the raloxifene. We will also read this in this chapter, because raloxifene is basically a estrogenic drug. Okay. So already we have seen this. So estradiol is the 17 beta estradiol. Time and again I am saying this is the main hormone. Estradiol plus is the main hormone in the normal menstruating females. Apart from this, there is progesterone, ovary, fetoplacental unit, menstrual cycle. Already we have discussed. So two times, one is the follicular phase, two phases of the cycle. One is the secretory phase. First, only a single ovum is normally released from the ovaries in each month, so that normally only a single fetus will begin to grow at a time. So menstrual cycle is approximately 28 days. Normal range is 24 to 35 days. It varies from 24 to 35 days. Cycle begins at the onset of the puberty and continues uninterrupted until menopause. So what happens again when there is delayed puberty? In that cases, we can treat those patients with the estrogen. So because for the puberty estrogen is needed. Cycle day 1. What is the day 1 of the cycle? Arbitrarily defined as the first day of the menstruation. Usually the first day of the menstruation is the day 1, and accordingly we count. Okay. So ovulation occurs usually at the mid portion, that is day 14. So after menstruation, the rest day up to day 14 is the follicular phase, where the estrogen is the predominant hormone, and after 14 to 28 days, progesterone is the predominant hormone. So you can see from this graph. So this is the blue one is the estrogen ones, and the red one is the progesterone ones. Both of these secreted, but the estrogen is the main hormone in the follicular phase, and after that estrogen level decreases and the progesterone level increases. So when there is more estrogen, there is lining of the uterus builds up, that is more cells are builds up, and after when the progesterone takes effect, ultimately the lining breaks down, that is the endometrium becomes more into the secretory phase, and after that the menstruation happens. So follicular or proliferative phase, portion of the menstrual cycle before ovulation, the developing ovarian follicle produces most of the gonadal hormones which stimulate cellular proliferation of the endometrium, building up of the endometrial cells. And the luteal or the secretory phase is the second half of the menstrual cycle. Here the corpus luteum produces progesterone and the endometrium becomes secretory rather than proliferative. So it is clear about the two phases of the cell cycle, day 1 menstruation, after that follicular phase, estrogen, ovulation, and ovulation happens, there is pre-ovulatory surge of the LH and FSH, and due to that ovulation happens, and after the secretory phase where the progesterone takes effect, and this large amount of the progesterone is secreted from the corpus luteum, and if pregnancy happens, this corpus luteum persists, otherwise it becomes degraded and menstruation happens. So as the dominant follicle continues to grow, so one follicle becomes dominant from which the ovulation happens. It secretes high sustained level of the estrogen. The combination of the high estrogen levels and the rapid rate of the increase of the estrogen level ultimately causes a brief positive feedback effect, stimulating release of the both LH and FSH. So basically it is a feedback effect, positive feedback effect, and the resulting mid-cycle surge of the LH and FSH stimulates the dominant follicle to swell and to increase the activity of its proteolytic enzymes. Proteolysis happens. So approximately 40 hours after the onset of this LH surge, the follicle ruptures and ovulation happens. The same thing what I am discussing. So by this it happens. So estrogen ultimately leads to positive feedback effect. Due to this positive feedback effect, there is transient rise of the FSH and LH. LH is more, and due to the transient surge of the LH, there will be more proteolysis of this dominant follicle, and the ovum comes out approximately 40 hours after. If the oocyte becomes fertilized in the fallopian tube, that is if pregnancy happens, it reaches the uterus approximately 4 days after ovulation. 4 days, the gap is 4 days, and implants in the endometrium approximately 5 to 6 days after ovulation. So if there is no menstruation, if pregnancy happens, so it becomes fertilization of the sperm and the ovum happens in the fallopian tube, and it reaches the uterus approximately 4 days after ovulation, and approximately 5 to 6 days after ovulation, implantation of this into the endometrium happens. The cellular remains of the ruptured ovarian follicle becomes the corpus luteum. So what is the corpus luteum? So the cellular remains of the ruptured Graafian follicles, the dominant follicles, that becomes named as the corpus luteum. And it secretes both the estrogen and progesterone. Progesterone in the second half of the menstrual cycle causes the endometrium to switch from a proliferative to a secretory state. So that is the action of the progesterone. The endometrium begins synthesizing proteins necessary for the implantation of a fertilized egg if the fertilization happens. The blood supply to the endometrium also increases to provide increased nutrients if pregnancy ensues. So this is the difference. If the pregnancy happens, ultimately corpus luteum remains there, and from this corpus luteum large amounts of the estrogen and progesterone are secreted that helps in continuous support to the fetus. And if there is no pregnancy, ultimately it breaks down and ultimately menstruation happens. The corpus luteum has a lifespan of approximately 14 days. If fertilization and implantation do not occur within these 14 days of ovulation, corpus luteum becomes atretic and ceases its production of estrogen and progesterone. The endometrium lining sheds, and this is known as the menstruation. The shedding of the endometrium line, this is the menstruation. If there is no fertilization, then the corpus luteum ultimately sheds. In the absence of the estrogen and progesterone, inhibition of the gonadotropin is removed, production of the FSH and LH increases, and beginning of another menstrual cycle. So ultimately it continues. The menstrual cycle continues. And if fertilization and implantation occurs, blastocyst is formed. Blastocyst is the nascent fetus, and from this blastocyst, human chorionic gonadotropin is secreted, HCG. And this HCG stimulates the corpus luteum to remain viable and continue secreting progesterone. Ultimately, it supports continuing the pregnancy. Okay. So this is the neuroendocrine control of the menstrual cycle. What we have discussed. So basically, this is a feedback effect of pituitary, ovary, fallopian tubes as well as the endometrium. So you can see in the early follicular phase, there are neuronal oscillation in the hypothalamus known as the hypothalamic GnRH pulse generator, gonadotropin releasing hormone. This is synthesized from the hypothalamus in the brain that fires at interval with a frequency about 1 per hour. So burst of the gonadotropin releasing hormone are synthesized from the hypothalamus. This is the first one. You can see this is the first one. This gonadotropin releasing hormone acts on the anterior pituitary, and from this anterior pituitary, FSH, follicle stimulating hormone, and LH, luteinizing hormone are synthesized. So FSH and LH are synthesized when there is absence of the gonadotropin releasing hormone that is synthesized from the hypothalamus. And this FSH and LH acts on the growing follicles in the ovary, and already we have seen FSH and LH helps in the pre-ovulatory surge, and this ovulation can happen. They act in maintaining the corpus luteum, and this growing Graafian follicles, ovary, corpus luteum, estrogen and progesterone are secreted. Due to the surge, ovulation happens, and increased estrogen at mid-cycle ultimately stimulates the LH secretion, and this LH surge ultimately causes the ovulation. And increased progesterone, estrogen after ovulation inhibits again the FSH LH secretion, so that there will be no ovulation in the same cycle. That's why only single ovulation happens in one menstrual cycle of the 28 days, because when the estrogen and progesterone after ovulation, they causes the negative feedback effect on the FSH and LH, so that there will be no further FSH and LH surge in the latter part of the menstrual cycle. That's why usually a single ovulation happens in whole of the menstrual cycle. So this is the neuroendocrine control. So there is some different feedback mechanisms, feed forward and the feedback mechanisms from the hypothalamus, from the pituitary, and from the ovary. There are 3 levels, and due to the interconnection between the 3 levels, hormonal interconnection, the ovulation happens, and if the pregnancy happens, that will be continued. Mid-cycle there will be surge, already we have seen. The surge means the serum estradiol rises greater than 150 to 200 picogram per ml for approximately 36 hours, and that ultimately leads to a brief positive feedback effect and increase of the FSH and LH. And this mid-cycle surge ultimately causes follicle rupture and ovulation in 1 to 2 days. Follicle rupture means proteolytic enzymes comes, Graafian follicle, within the Graafian follicle, ovum is there, this burst open, ovum comes in the fallopian tubes. Secretory phase, ruptured follicle develops into the corpus luteum. The follicle, that is the dominant follicle from which the ovum comes out, that becomes corpus luteum after the ovulation. The same Graafian follicle is known as the corpus luteum. Large amounts of the progesterone and lesser amount of the estrogen is released under influence of the LH in the secretory phase of the menstrual cycle. And if in absence of the pregnancy, if the fertilization will not happen, corpus luteum ceases to function and steroid levels drop, and ultimately shedding of the endometrium happens and menstruation occurs. So the same thing you can see, this is the surge, this is the estrogen graph, and this is the progesterone graph in whole of the menstrual days. This is the day 1 of the menstrual period, and last is the day 28 of the menstrual period. So how the changes happens? So you can see progesterone is there in the follicular phase also, but in the lower level, and the estrogen level is also there in the secretory phase, but in the lower level in comparison to the progesterone. So the same thing you can see, this is the proliferative part, gradually builds up, and then secretory phase and menses. This is the endometrium, and this is the follicles in the ovary. So ovarian follicle, one follicle becomes dominant, Graafian follicle, dominant Graafian follicle, ovulation, and after ovulation the atretic part becomes the corpus luteum. The corpus luteum becomes atretic and menstruation happens if there is no pregnancy, and if there is pregnancy the corpus luteum remains, and from this large amount of the estrogen and progesterone are secreted to support the fetus growing, and this happens under the influence of the human chorionic gonadotropin that is secreted from the chorion of the fetus, blastocyst. Now what are the actions of the estrogen? Physiological and pharmacological action, developmental actions, largely responsible for the pubertal changes in the girls and secondary sexual characteristics. All secondary sexual characteristics, all pubertal changes happens due to the estrogen increase in the pubertal period. If that does not happen, so there will be delayed puberty. In that cases, we can treat with the estrogen. Okay. Causes growth and development of the vagina, uterus and fallopian tubes, and contributes to breast enlargement. Contribute to molding of the body contours, shaping the skeleton, causing the pubertal growth part of the long bones and epiphyseal closure. So bone growth is very important actions of the estrogen. That is also part of the testosterone also. growth of the axillary and pubic hairs, pigmentation of the genital regions, regional pigmentation of the nipples and areola occurring after the first trimester pregnancy. This all happens due to the estrogenic actions. Estrogens also play important developmental roles in males, what I am talking. So in boys, estrogen deficiency diminishes the pubertal growth spurt and delays skeletal maturation and epiphyseal closure, so the linear growth continues in the adulthood. So estrogen is also secreted, already we have seen, all these are secreted from the cholesterol. So from the cholesterol, ultimately the androstenedione and dihydrotestosterone is formed, and from this, by means of the aromatase, it is converted to the estradiol, and estradiol then it's converted to estrone and estriol, and some part of this testosterone also converted to this estradiol, estrone and estriol. So in males approximately 2 to 20 microgram per day estrogen is needed, and this is particularly needed in the pubertal phase, otherwise there will be no growth. Okay. Estrogen deficiency in men leads to elevated gonadotropins, macroorchidism and increased testosterone levels, and also may affect carbohydrate and lipid metabolism, fertility in some individuals. Metabolic effects: long-term administration of the estrogen is associated with decreased plasma renin, angiotensin converting enzyme and endothelin 1. What happens? Estrogen usually have been shown to decrease the LDL level and increase the HDL level. So we know LDL is the bad cholesterol part and high density lipoprotein, HDL is the good lipoprotein part. So basically in case of the females, if there is sufficient estrogen, there is decreased atherosclerosis. That's why the chances of the atherosclerosis or myocardial infarction or the other cardiovascular problems are less in females in comparison to the males. So that is the physiology. Estrogen actions on the vascular wall also causes increased production of the nitric oxide. They causes increased production of the prostacyclin I2. All these helps in the vascular endothelium growth. So it promotes vasodilation, retard the atherogenesis. Increased plasma levels of the cortisol binding globulin, thyroxine binding globulin, all this can happen. Estrogen increase bone mass, what we are talking. So estrogens directly regulate the osteoblast and increase osteocyte survival by inhibiting the apoptosis. So in the osteoporosis class, you have also seen that there is a cycle of the bone gradually destroyed and again the bone builds up. So this cycle will be lost if there is no estrogen as well as the testosterone. That is needed. Estrogen slightly elevated, these have already discussed. So basically they helps in the metabolic profile of the persons. Estrogen increases the nitric oxide synthesis in the vascular endothelium, which is a vasodilator. So ultimately it helps decreasing the blood pressure. Estrogen helps in decreasing the LDL cholesterol and increasing the HDL cholesterol. So HDL by LDL ratio is increased, that helps in decreasing the atherosclerosis, ultimately decreasing the myocardial infarction, ischemic heart disease, all this in the females. So these are the estrogen preparations. Natural estrogen, the natural estrogen estradiol, usually if it is taken by mouth, it is destroyed in the liver. So basically natural estrogen, if it's to be given, it is usually given by intramuscular injections. Otherwise newer synthetic steroidal as well as non-steroidal estrogen preparations are there that can be given orally. So estradiol, estrone, estriol is there. Synthetic ones are ethinyl estradiol, mestranol, quinestrol and tibolone. These are the names of the synthetic steroidal estrogen. Synthetic non-steroidal estrogen is the stilbestrol and dinestrol. These are the non-steroidal synthetic estrogen, and some conjugated estrogens are lesser used nowadays, mixture of sodium estrone and sodium equiline. So natural estrogen, already we have seen estrone, estradiol and estriol. Estradiol, already we have seen, this is the predominant and most potent estrogen hormone in a non-pregnant women between her menarche and menopause. That is the normal menstruating women. Estradiol is the predominant estrogen. Estrone is the predominant estrogen in postmenopausal women. So after menopause, estrone is the main hormone. Estriol, this is the predominant estrogen in pregnant women. When the pregnancy happens, the estradiol changes into the estriol. All this ultimately interconnected. And estradiol is a very minute quantities. It is produced by the fetal liver during the pregnancy. Estradiol is a major estrogen secreted by the ovary. It is synthesized in the Graafian follicle, corpus luteum and also placenta, and the source material is the cholesterol. From cholesterol all these are synthesized. So this is the way by which it is synthesized. So cholesterol is the first one. Ultimately dihydroandrosterone, epihydrosterone. This is androstenedione is formed, and this androstenedione is the area from which testosterone and other female hormones are synthesized. You can see androstenedione can be converted to testosterone. Testosterone by means of the aromatase P450 aromatase, it is converted to estradiol. Androstenedione directly can be converted to estrone, and estradiol can be converted to estrone and then estriol also. So from cholesterol, androstenedione is formed, and from this different female sex hormones are produced. Mechanism of action. So basically there are two receptors of the estrogen, estrogen receptor alpha and beta. These are present within the nucleus of the cells. So nuclear receptors. So when the estrogen is given, estrogen ultimately acts on the nuclear receptors, and then post-transcriptional modification happens and the different effects occurs. Now there are different formulations of the estrogen that can act on this estrogen receptor in differently. So some agents are there, they can give agonistic action on some estrogen receptor in some organs, as well as some antagonistic action on some estrogen receptor in some other organs. So ultimately it varies. We will come to this. So where this estrogen is used, therapeutic uses of the estrogen, already we have seen. So delayed puberty or primary hypogonadism. Primary hypogonadism happens in one syndrome. You have read in the biochemistry, Turner syndrome. You have read about the Turner syndrome. So in Turner syndrome is an example where there is primary hypogonadism happens, where we can use the estrogen. Apart from this, if there is delayed puberty, we can use the estrogen. So delayed puberty means after the 12 to 13 years, if there is no signs of the puberty, there is no signs of the thelarchy, that is the breast enlargement, no signs of the genital hair development or other problems by which we can identify. So the estrogen usually can be given. So after the menarche, usually the estrogen most commonly used as a part of the contraceptive pills, contraception. So we will read contraception in the next class. So estrogen now most commonly used as a part of the contraceptive pills or different other contraceptive methods. Apart from this, this can be used in the dysmenorrhea and dysfunctional uterine bleeding. Dysmenorrhea, that is the menstrual period is not is disbalanced, as well as the dysfunctional uterine bleeding, more bleeding is happening. In those cases we can use the estrogen. And after menopause, again one of the most important area where we can use the estrogen is the hormone replacement therapy, which is quite controversial. We will come to this. So hormone replacement therapy after menopause, we can use the estrogen. Apart from this, senile vaginitis or ectopic vaginitis, in those cases we can use the estrogen. So the two major uses of the estrogen are, one is the menopausal hormone therapy or hormone replacement therapy, and as a component of the contraceptives. The effective dose of the estrogen used for menopausal hormonal therapy is much lesser than that is used in the contraceptive. So therapeutic uses, hormone replacement therapy. Why in postmenopausal women hormone replacement therapy is needed? So we have seen that estrogen, if there is very less estrogen, already we have seen in the postmenopausal women the estrogen release is only 1 to 10 microgram per day, mainly the estrone is there. So ultimately there will be hot flashes, there will be increased sweating, different other psychological problems, emotional problems, cardiovascular problems, all can happen. Osteoporosis, vasomotor symptoms, cardiovascular symptoms, urogenital atrophy, neuroprotective CNS effects, all this can happen. That can be tackled if we give some hormone replacement therapy, that is replaced with the estrogen. If estrogen replacement therapy can be given in primary ovarian failure, dysfunctional uterine bleeding, dysmenorrhea, acne or hirsutism, because acne happens due to the increased testosterone level both in the boys as well as in the girls in the pubertal age group. Prostate carcinoma, in those cases we can use the estrogen also. Osteoporosis, hormone replacement therapy for postmenopausal women. So it has been seen in the postmenopausal women there is more chances of the osteoporosis. So more chances of the fracture, both in the vertebral fracture as well as the peripheral fractures, femoral fractures like this. So most fractures in the postmenopausal women occurs in the women without a prior history of the osteoporosis, and estrogens are the most efficacious agent available for prevention of fractures at all sites in such women. Estrogens act primarily to decrease the bone resorption Consequently, estrogens are more effective at preventing rather than restoring the bone loss, and the most effective in treatment is initiated before significant bone loss occurs. So, this has to be started early after the menopause. An appropriate diet with adequate intake of calcium and vitamin D is needed. Weight bearing exercise enhance the effect of the estrogen treatment. Vasomotor symptoms, that is quite problematic for the menopausal women. That's why usually the hormone replacement therapy is given. Decline in ovarian function at menopause is associated with vasomotor symptoms. Characteristic hot flashes may alternate with chilly sensation, inappropriate sweating, and less common paresthesias. Treatment with estrogen specific is the most efficacious pharmacotherapy. Medroxyprogesterone acetate may provide some relief of vasomotor symptoms. Alpha 2 adrenergic agent like clonidine. So clonidine is an alpha agonist agent, alpha 2 agonist agent that can also be used here, that diminishes vasomotor symptoms in some women, presumably by blocking the CNS output that regulates the blood flow to cutaneous vessel. So mainly the problems is the hot flashes and alternating chilly sensations that can be decreased by estrogen, that can also be treated by the clonidine. Cardiovascular, the incidence of the cardiovascular disease is low in premenopausal women, but it rapidly increases when the estrogen level falls down in the menopausal women. Estrogen produces a favorable lipoprotein level, already we have seen, increased HDL level, inhibits the response to vascular injury. However, estrogens also promote coagulation and thromboembolic effects. So, in high doses of the estrogen ultimately leads to more thromboembolism. That is also problematic. So, combined estrogen progesterone therapy is usually given, is associated with decrease in heart attacks in younger women. Vaginal dryness and urogenital atrophy, that is also quite common in menopausal women. Loss of tissue that lines the vagina or bladder leads to a variety of symptoms in many postmenopausal women. Vaginal dryness, itching, painful intercourse, swelling of tissues in the genital region, pain during urination, all can happen. Urinary incontinence, all this can be used usually by estrogen. Usually some estrogen cream is used. Okay. For relief of the vulvar and vaginal atrophy, local administration of the estrogen as a vaginal cream may be considered. Now the problems of the hormone replacement therapy, the most common problem is the venous thromboembolism. So thromboembolism, so the blood vessels can be blocked anywhere. So that can also lead to increase of the heart attack paradoxically, or some deep vein thrombosis can also happen. Gallstone can happen, uterine bleeding, dysfunctional uterine bleeding, it can be used as a treatment, but ultimately it can also lead to some dysfunction. Mood changes, breast cancer and migraine, all can this happen. Tibolone is basically a non-steroid synthetic estrogen developed specifically to use for the hormone replacement therapy, where the adverse effects of the synthetic estrogens, steroidal estrogens are less. In a dose of 2.5 mg daily, it suppresses menopausal symptoms, lowers the raised gonadotropin level. No endometrial stimulation has been noted. Urogenital atrophy, psychological symptoms, libido and osteoporosis are improved similar to other forms of the hormone replacement therapy. So the problems of the hormone replacement therapy, what you can conclude, that in postmenopausal women the estrogen is less, so we can supplement the estrogen. But the problems of the estrogen is that we know that estrogen gradually builds up the endometrial cells. So always there is chances of the endometrial carcinoma, endometrial cancer can happen if we can give large doses of the estrogen. Breast cancer can happen if we are giving the large doses of the estrogen, because they can also stimulate the estrogen receptor in the breast. So, third one is the thromboembolism is the most common effect, and that thromboembolism, thrombus and embolus can lodge anywhere in the artery and can block. So there may be deep vein thrombosis, there may be stroke, there may be heart attack, all this can happen. So ultimately it has been decided by different types of the trials that if we are using very low doses of the estrogen, that decreases the adverse effect of the estrogen, and ultimately that can help in mitigating these different types of the problems. And in otherwise, if we can use progesterone along with estrogen, that progesterone part can cut off some adverse effect of the estrogen. Okay, but the advantages of the estrogen are also somewhat cut off by the progesterone, because the actions of the progesterone is just opposite to that of the estrogen. So the main indication of the hormone replacement therapy is the vasomotor and other symptoms in perimenopausal period. So now it has been advocated that just after menopause, if the patient is younger, before the 60 years, we can use the hormone replacement therapy. But if the age is greater than 60, we should not use the hormone replacement therapy, because in trials it has been seen to increase the mortality from the stroke, different thromboembolic disorder. So it should be used at the smallest effective dose. The smallest effective dose. This is also used in case of the contraception also. So in contraceptives also we are using the smallest effective dose of the estrogen and the progesterone, and further lower doses is needed in case of the hormone replacement therapy, and for the shortest duration. So smallest effective dose and shortest duration estrogen is usually used in case of the hormone replacement therapy. Young women with premature menopause clearly deserve the hormone replacement therapy. So you know that in some women there may be premature menopause. That's the menopause happens before the normal ages of approximately 45 to 50. So this can happen in the 30s. So when the menopause happens, there will be loss of the estrogen support. So there will be different types of the problems already we have seen. So in younger women, it is advocated. So when there is premature menopause, it is advocated. Just in the perimenopausal period, that is, the patient is ongoing to the menopause, where there are different types of the problems like hot flashes, increased sweating, mood changes. If the patient is younger age, if the age of the patient is less than 60, in those specific cases, in case to case basis, we can use the hormone replacement therapy by estrogen, and this should be done for the smallest effective doses and in the shortest duration of the time to decrease the adverse effects of the estrogen. The most problematic adverse effect of the estrogen in hormone replacement therapy is the endometrial carcinoma can happen, breast carcinoma can happen, thromboembolic disorders can happen, gallstones can happen. Okay. So perimenopausal women should be given cyclic hormone replacement therapy rather than continuous hormone replacement therapy. So there should be a gap between the hormone replacement therapy is given. It should not be given continuously. Hysterectomized women should receive estrogen alone. That is where the estrogen has been cut off, should be given estrogen alone, while those with intact uterus should be given estrogen plus progesterone, because it helps mitigating the different types of the adverse effects. Combined hormone replacement therapy at conventional dose may even increase the risk of venous thromboembolism, myocardial infarction and stroke in elderly women. So with increased age, the adverse effects will be more. So we should not give in more increased age, it should be given in younger age group. Combined hormone replacement therapy increases the risk of breast carcinoma, already I have said, gallstone and also migraine. The need for hormone replacement therapy should be assessed in individual women and not prescribed routinely. So it is clear. So what is the estrogen? What is the effects of the estrogen and where the estrogen is used? And one of the most important is the hormone replacement therapy, but there are pros and cons of the hormone replacement therapy. So this can come into your exams. Okay. So if you can understand about the actions of the estrogen and the adverse effects of the estrogen, then it will be clear to you that in case to case basis where the estrogen replacement therapy should be given as a hormone replacement therapy. It should not be given as a blanket therapy to all postmenopausal women. Absolutely no. It should be given to case basis, particularly in younger age groups, in premature menopause, in those perimenopausal women where the hot flashes will be more, the age is less than 60. In those cases only, and if there is no history of any breast carcinoma or endometrial carcinoma, we can use the estrogen replacement therapy. Apart from this, it can be used in delayed puberty of the girls like Turner syndrome, hypopituitarism. Pubertal changes are brought about by estrogen therapy, dysfunctional uterine bleeding, dysmenorrhea, carcinoma prostate. Details is not required, but in these cases also estrogen is usually used as a treatment. Adverse effects already we have discussed. In males, if the estrogen is given in high doses, that can give to gynecomastia, feminization and decreased libido, because it can be used, it is also used in the treatment of the prostate cancer, but these are the drawbacks. So in prostate cancer, if we are using in doses of the estrogen, these adverse effects can happen. In females, in normal doses, it can lead to breast tenderness, migraine, withdrawal bleeding, amenorrhea, endometrial hyperplasia, risk of breast carcinoma, vaginal cervical adenocarcinoma in female offspring. This can also happen. And in both sexes, gallstone, gallbladder disease, hepatic dysfunction, thromboembolic disorder, diabetes, fluid retention, all this can happen. So different metabolic problems happen. Fluid retention is another common cases. There will be edema in the legs. If the estrogen therapy is given, usually we have to use some diuretics like torsemide or furosemide to decrease this increased edema. Contraindications. So when we are using the estrogen, we have to see whether these diseases are present or not. If these are present, we should not give estrogen, like gallbladder disease, thromboembolic disorders, history of gallbladder disease, history of thromboembolic disorder. If there is pregnancy, already the patient is pregnant, hepatic dysfunction, some hepatic problems is there, already there is long-standing diabetes, mainly the uncontrolled diabetes, estrogen dependent breast carcinoma is there, endometrial carcinoma, endometriosis, this is a disease of the endometrium, undiagnosed genital bleeding. So we don't know why the bleeding is happening in those cases. This is contraindication to the estrogen therapy. Now this is very important, selective estrogen receptor modulator. What I am talking, that when the estrogen is given, estrogen acts on the estrogen receptor alpha and beta, and these estrogen receptors are present in different types of the organs, and there are some agents that can be used as an agonistic agent in some organs and antagonistic or partial agonistic actions in some other organs. So context dependent activity, organ specific activity of some estrogenic drugs are there. So these are known as the selective estrogen receptor modulators. So they are modulating the estrogen receptors selectively in different organs. SERM. So these are the groups of drugs. These are synthetic, non-steroidal and tissue selective estrogenic and anti-estrogenic action. Some tissues estrogenic action, some tissues anti-estrogenic actions. The pharmacological goal of these drugs is to produce the beneficial estrogenic actions in certain tissues like bone, brain and liver, but antagonistic activity in tissues such as breast and endometrium. So these drugs are developed so that we can use these drugs in some diseases, so that there will be some targeted action of estrogen on those organs without lesser adverse effects in other organs. Okay, that's why the SERMs are used. Currently approved drugs, there are 3 drugs that comes under the broad headings of the selective estrogen receptor modulator: tamoxifen, citrate, clomiphene and raloxifene. Tamoxifen, raloxifene and clomiphene. Tamoxifen, raloxifene and clomiphene. First coming to the tamoxifen. Tamoxifen, citrate or tamoxifen, it exhibits anti-estrogenic, estrogenic and mixed activity depending on the species and the target genes measured. It also acts on the different other species also, different other animals also differently. Tamoxifen inhibits the proliferation of the cultured human breast cancer cells. So it can be used in the breast cancer. So it has been seen that in breast cancer cells, they can inhibit the breast cancer cells. It can reduce the tumor size and number in women, yet it stimulates the proliferation of the endometrial cells and can cause the endometrial thickening. It has an anti-resorptive effect on bones, and in humans it decreases the total cholesterol, LDL, lipoprotein A, but does not increase HDL and triglyceride, and it also upregulates the TGF-beta. So you can see it is a potent estrogen receptor antagonist at breast, blood vessel and peripheral sites. So the estrogen receptor, those are present in the breast, endothelium or blood vessels and different peripheral sites. Here it acts as an antagonist, while potent estrogen receptor agonist at the uterus, bone, pituitary and liver. So the estrogen receptors in this, it acts as an agonist. So some other organs is as an antagonist and agonist. This happens because when these drugs acts on the estrogen receptor alpha and beta, there will be some configurational changes, and according to the configurational changes, different transcriptional, post-transcriptional modification happens, and this also takes the help of the different co-activators and co-repressor proteins. That is, in one organ, when these drugs is given, they attaches with the estrogen receptor and causes some configurational changes, so that some co-activator protein and some co-repressor protein also acts on it. So some activators activates it or repressor represses it, and in some other organs they changes the configuration of that receptor some other way, so that the co-activators and co-repressors also act in some other ways. Because of these actions of these co-activators, co-repressors, as well as the configurational changes of the receptors, the different context dependent changes in the actions of these agents on different organs have to be seen. So there will be some agonistic actions in some organs of these agents and antagonistic actions in some organs in these agents. So pharmacological action is anti-estrogenic action. It inhibits the human breast cancer cells and hot flashes. Estrogenic action, it can cause in the endometrial proliferation, improvement in bone density, decrease in total LDL cholesterol, but there is no change in HDL and triglyceride, and increase in thromboembolism. So increased thromboembolism, which is an adverse effect of the estrogen, is also there with the tamoxifen. Side effects are the hot flashes, vaginal bleeding, vaginal discharge, menstrual irregularities, dermatitis, increased risk of thromboembolism, anorexia, depression, mild leukopenia, all can happen. So where it is used, tamoxifen, it is used in both pre and postmenopausal breast cancer. Now one of the very important drug for the treatment of the breast cancer is the tamoxifen, very effectively used. It is also used in primary prophylaxis of the breast cancer in high risk women. High risk means if there is history of the breast cancer in their first order relatives, that is in their mothers or their sisters, they are the high risk for the breast carcinoma. In those we can use the tamoxifen as prophylaxis for the breast cancer also. Postmenopausal osteoporosis, lesser use, and male infertility, in some of the cases it is used. But remember, tamoxifen is a selective estrogen receptor modulator that is mainly used as a treatment as well as the prophylaxis of both pre and postmenopausal breast carcinoma. Clomiphene is basically a derivative of the tamoxifen. Chemical structure and all these are similar pharmacological actions used to treat estrogen receptor positive breast cancer. Basically, the adverse effects of the clomiphene is somewhat lesser than that of the tamoxifen, but more or less these two are similar. Raloxifene action is somewhat different. This is different to that of the tamoxifen. This is also another the selective estrogen receptor modulator. Different pattern of action. It is an estrogen partial agonist in bone and cardiovascular system. Partial agonist in bone and cardiovascular system, hearts and blood vessels, and antagonist in the endometrium and breast, both. So it has high affinity for both estrogen receptor alpha and beta, and they basically acts on a DNA target known as the raloxifene response element, RRE. So again, this is a DNA means this is an area where this attaches and ultimately configurational changes happens, different co-activators, co-repressor happens, and it has been seen that they have partial agonistic action on different bone cells, different cardiovascular actions like hearts and blood vessels, and they have antagonistic action on the endometrial cells as well as the breast cells. So it improves the bone mineral density and prevents bone loss, reduces the incidence of the compression vertebral fracture, decreases the LDL, no increase in the HDL and triglycerides, does not stimulate endometrial proliferation, so there is less chances of the endometrial carcinoma, anti-proliferative effect on estrogen receptor positive breast tumor and cancer cell lines. So the side effects are hot flashes, leg cramps, deep vein thrombosis, pulmonary embolism, this can happen. And the main use of the raloxifene is in the osteoporosis. So in the osteoporosis class, you have heard about the raloxifene as a drug. So raloxifene is a second line drug for the treatment and prevention of osteoporosis in postmenopausal women. First line drug, what is the first line drug? First line drug is the bisphosphonates. So you have read about the bisphosphonates. So bisphosphonate is the first line drug for the postmenopausal osteoporosis, very common in our country also. And the second line drug, there are different other drugs. One of them is the raloxifene. Apart from this, it is used in the secondary prevention and treatment of the vertebral fractures, prevention of the breast carcinoma, alternative to the hormone replacement therapy. So selective estrogen receptor modulator is a very important topic. It frequently comes in the exam. So you have to write all this, how this selective estrogen receptor modulator is different from the normal estrogen, and the actions of the tamoxifen and raloxifene. So tamoxifen is basically mainly acts in the breast carcinoma, and raloxifene mainly acts in the osteoporosis, postmenopausal osteoporosis. Ormeloxifene is another type of the SERM, which is a estrogen antagonist at breast and uterus, and anti-estrogenic as well as some anti-progesteronic action also. It is used as a dysfunctional uterine bleeding as a non-hormonal oral contraceptive. So basically ormeloxifene can be used as a contraceptive now. Adverse effect of nausea, headache, weight gain, fluid retention these are the normal adverse effects. Next, coming to the anti-estrogens. So previously we have seen the selective estrogen receptor modulator. These are the direct anti-estrogens. So there are two, one is clomiphene and that is the fulvestrant. Fulvestrant is not pure anti-estrogen, that is basically a estrogen receptor down regulator, will come. So these compounds are distinguished from the SERMs in that they are pure antagonists in all tissue studies. So when they are used, they have agonistic actions on the estrogen receptor alpha and beta wherever this is present, irrespective of the organs. Clomiphene is mainly approved for the treatment of the infertility in anovulatory women, very commonly used. In our modern days, the infertility is very common. You will see the infertility clinic everywhere. Clomiphene is very commonly used in all these cases. Fulvestrant is used mainly in the treatment of the breast carcinoma in women with disease progression after tamoxifen. So if after giving tamoxifen the breast carcinoma is not controlled, it is progressing, we can use the fulvestrant. So clomiphene citrate, it is a competitive antagonist of estrogen receptor at the hypothalamus. So in the hypothalamus there are estrogen receptor, so it is a competitive antagonist. So when it antagonizes this estrogen receptor in the hypothalamus, that inhibits the negative feedback effects on the release of the GnRH. So the GnRH will be released more. So the release of the FSH, LH at each secretory pulse is enhanced. So it is clear. So basically from the hypothalamus gonadotropin releasing hormone is released. Already we have seen this flow chart. This gonadotropin releasing hormone acts on the anterior pituitary to secrete the FSH and LH, and this FSH and LH helps in the secretion of the estrogen and progesterone from the ovary. So what happens when this estrogen and progesterone is already there, they gives a negative feedback effect on the hypothalamus, so that there will be no more release of the gonadotropin releasing hormone, no more release of the FSH and LH. So ultimately it is a negative feedback effect. When this clomiphene is given, this clomiphene basically acts on this negative feedback mechanism. They goes to the brain and they acts on the estrogen receptor alpha and beta in the hypothalamus. When they act on this hypothalamus, the negative feedback effect has been lost. So negative, duto negative hoye gelo mane ki positive holo. So there will be more release of the FSH and LH, and again there is more release of the estrogen and progesterone. And ultimately there is more chances of the ovulation, there is more chances of the fertility, more chances of the pregnancy. Okay. So uses female infertility due to anovulation, mainly anovulatory cycles. So anovulatory cycles means cycle is continuing but ovulation is not happening due to the less surge of the FSH, LH, less estrogen and progesterone. Male infertility due to oligospermia, it can be used but the success rate is very less. In vitro fertilization also clomiphene is used. Clomiphene is usually used in cycles. Usually it is given for the 5 days after the menstrual period from the day 1, and usually the 6 cycles are seen in every month. After the 6 months, if it is not continuing, then the other measures are usually takes over. So clomiphene citrate, remember, is a anti-estrogen that mainly acts on the estrogen receptor alpha and beta in the hypothalamus, and when it acts, the negative feedback effects will be lost, so that there will be more release of the FSH and LH from the pituitary that acts on the ovary, and there will be more release of the estrogen and progesterone, and this helps in the more chances of the ovulation in the anovulatory cycles that ultimately leads to infertility. So that can be used for the treatment of the infertility in the anovulatory cycles, used in the in vitro fertilization, that is the fertilization is done in vitro, not in vivo. Test tube baby. The in vitro fertilization also clomiphene is used, and also in oligospermia, that is the sperm count is less in males. That also leads to infertility, but here the success rate is less. Adverse effects of the polycystic ovarian disease. Multiple pregnancy, very common. You can see that when this clomiphene is used for the, in case of the infertility, usually multiple pregnancy happens. Usually twins usually gets birth. Risks of ovarian cancer is also there, prolonged use. Because the ovaries are continuously getting stimulated, we are getting more estrogen by giving the clomiphene. Hot flashes may be there due to antagonism of the peripheral estrogen receptor. Peripheral estrogen receptor becomes antagonized due to this feedback mechanism. Weight gain can happen, reversible alopecia, hair loss can happen, blood vision can happen, high incidence of the luteal phase dysfunction in clomiphene-induced cycles due to inadequate progesterone production. That can also happen. So that is the problem of the clomiphene citrate. Next, lastly, coming to the fulvestrant. Fulvestrant is also anti-estrogen but somewhat different. It is basically known as the selective estrogen receptor down-regulator. So basically they are down-regulates the estrogen receptor so that there will be less actions like that. So it is a pure estrogen antagonist introduced for the treatment of the metastatic estrogen receptor positive breast cancer in postmenopausal women and tamoxifen resistant breast cancer. So it is used mainly in the tamoxifen resistant breast cancer, inhibits estrogen receptor dimerization, estrogen receptor interactions with DNA, disease prevention, and receptor degradation is enhanced. So ultimately they leads to receptor degradation, receptor down regulation. Adverse effects are hot flashes, nausea, headache, back pain, pharyngitis. So if you are asked that what are the drugs that can be used for the treatment of breast carcinoma, the answer is the tamoxifen, toremifene, and the fulvestrant. Tamoxifen, toremifene is the selective estrogen receptor modulator and fulvestrant is the selective estrogen receptor downregulator. If you are asked what is the drug that is used for in case of the infertility, that is the clomiphene or clomiphene citrate. Clomiphene is the pure anti-estrogens. Anti-estrogens means it is antagonizing estrogen not in the ovary but in the brains, in the hypothalamus, so that the negative feedback effects will be lost and more release of the estrogen happens in the ovary. Okay. Lastly, estrogen synthesis inhibitors are there. Testosterone is converted to estradiol. Already we have seen. So from the cholesterol, androstenedione and testosterone is formed, and this testosterone by means of the aromatase, P450 aromatase, it is converted to estradiol, and from this estradiol, estriol and other estrone are formed. So aromatase inhibitors basically blocks this aromatase. So there are two types, first generation and second generation. First generation is aminoglutamate, not used nowadays. Second generation may be steroidal and non-steroidal. Steroidal is the type 1. This is also irreversible. Example is the formastine and exemestane. Formastine, exemestane, and non-steroidal type 2 is the reversible aromatase inhibitor. Example is the anastrozole, letrozole, fadrozole, and vorozole. Of this, letrozole, anastrozole very commonly used. These are basically used in the estrogen receptor expressing breast carcinoma resistant to tamoxifen. So we can see the third agent, if it is breast carcinoma is not controlled by the tamoxifen and fulvestrant, then we have to use the aromatase inhibitor. Aromatase inhibitor is the last line of the agents. Along with androgen antagonist, it is also used for the treatment of the precocious puberty. So estrogen is used in case of the delayed puberty, but precocious puberty is if the pubertal changes happens in the 5, 6 or 7 years precociously, that is also a disease. Here we can use the aromatase inhibitors. First degree treatment of the excessive aromatase syndrome, this is another disease. Adverse effect of the hot flashes, joint pain, thromboembolic disease all can happen. So you can see this is the cholesterol, from this the different steroids or hormones are produced. This is the androstenedione, and from this testosterone is produced, and from this testosterone by means of the aromatase estradiol is produced, and this estradiol can be changed into different other agents. So you can see estrogen synthesis inhibitor, aromatase inhibitor, you have to remember the names. The most commonly used, the irreversible and reversible ones, irreversible formastine, exemestane, and the type 2 are reversible is the anastrozole, letrozole, etc. These are mainly used in the tamoxifen resistant breast carcinoma that express the estrogen receptor. Along with androgen antagonist, it is used in the treatment of the precocious puberty and the first degree treatment of the excessive aromatase syndrome. This is all about today. In the next class, we will read about the progesterone and the contraceptives. So from the today's class, very important is the estrogen. From the estrogen, the controversies and the use in case of the estrogen replacement therapy or hormone replacement therapy. Everything about the hormone replacement therapy, what are the adverse effects of the estrogen, what are the other indications of the estrogen, selective estrogen receptor modulator, very important, everything about the SERMs, and the fulvestrant is the estrogen down regulator, and clomiphene. Clomiphene can also come as a short note or as a treatment of the infertility. Any questions? Okay, thank you.